Well, greetings everyone and welcome to the Resuscitation VCast. This month we're going to spend a little time listening to a really smart emergency physician talking about electrocardiography. And I'm talking about Dr. Jeff Tabus. Jeff is a professor of emergency medicine at UCSF and works at San Francisco General Hospital. He has a wonderful EKG workshop that he does around the country. And he, in 2009, did this workshop at the Resuscitation Conference in Vegas. He's going to be back this year, 2013, in Vegas, doing that Resuscitation EKG workshop. And so I'm going to present just a little snippet of the 2009 version so you get a little sample of what he has to offer.
Welcome to Approach to the Critical EKG. Goals. So we're going to emphasize a methodical approach to assessment. We're going to focus on findings associated with life-threatening conditions. We're going to improve our identification of significant abnormalities. We're going to emphasize the differential diagnosis. So I've tried to distill down, it's still a lot, but it's more like 50 or 75 things that you keep in mind to improve your acute reading.
Okay, well, those are the objectives for the full workshop, which is probably about a 3-hour workshop. And for this little section, we're just going to focus on some things that he discussed regarding STEMI versus benign early repolarization, one of the real quandaries that we face when we see EKGs that have ST segment elevation. So we're just going to focus on his comments regarding ST elevation versus benign early repolarization. You can get the full audio from CME Download or just come to Vegas and listen to his workshop.
So a 45-year-old male is sent from clinic with several days of stabbing chest pain. This is an EKG I got. Clinic MD obtained the EKG and called the ambulance to transfer the patient to your ED. And then this is the EKG. So what do you guys think? Yeah. So first thing you do is look at the rate. The rate's 79. If it's not listed there, you can say too slow, too fast, or okay. Then you look at the rhythm. Is it coming from the sinus node? It's upright in 2 and inverted in AVR. Then you look at the QRS width, and it's not wide. And then you look at the ST segments, and you see that your ST segments are elevated, and this doctor appropriately assessed there was elevation there. But when I looked at this, I said, as this doctor said, I thought that this is probably benign early repol. So we're going to go over why this is benign early repol, but I ended up actually discharging this patient. All right, so the 6 causes of ST elevation. The main differential that we are making as acute care providers is this benign early repol or acute MI? 95% of the time, that's the decision. So that's really where we want to focus our energies. About 5% of the time, it could be pericarditis, LV aneurysm, Prince-Metal's angina, or bundle branch block. Okay? So the first question is, how do you even decide if there's ST elevation or depression? Where do you measure it? Okay? I'm going to tell you that you measure it at the end of the QRS. Now, if you look in the books, it all varies. So your ACLA S book, maybe not this current rendition, but the earlier edition, said to measure it 2 small boxes out. The Bible of EKG reading, which is Marriott's electrocardiography, says read it at the takeoff. We had an EKG guru who said read it at the takeoff. I actually contacted the new editor. Everyone, when I asked the cardiologists, they all referred me to the current editor of Marriott's, and he said that you read it at the takeoff. There's evidence if you read it 2 small boxes later, it loses its sensitivity and specificity. So measure it at the takeoff. So what is the takeoff? How do you know where the ST segment starts? Well, you look at the QRS, and the QRS should always be a nice, straight line. Where the line starts to change its slope is the J point. Okay? So the J point is where the line starts to change its slope after the QRS, and you compare that level to the level of the TP, not to the PR, but to the TP. So I'm going to measure it right here, and I'm going to compare that to this TP. So this guy has like 1, 2, 3 millimeters of ST depression.
Okay, so that guru that Jeff is talking about is Dr. Galen Wagner, who is an internationally known cardiologist and electrocardiographer. And what Galen Wagner says, I think, goes. He's the editor of the Marriott textbook now, and very, very well known. So 2 important points that Jeff made. Number 1, the J point is where you measure the ST segment for ST segment elevation or ST segment depression. That is the point at which the QRS complex ends. You don't measure 1 or 2 boxes after the QRS. Jeff is saying you measure right at the point at which the QRS complex ends, also known as the J point. Second important point, and another source of confusion, is that the electrocardiogram's isoelectric point is the TP segment, not the PR segment. Because remember, if you have pericarditis, the PR segment is going to be screwed up. It's going to be pointing down. So the isoelectric point upon which you measure for ST elevation or ST depression, the isoelectric point is the TP segment. And Jeff's going to point that out as he already has. He's going to point it out a couple more times.
So what do you think this patient has? So you measure it right there. That's where your slope starts to change. You compare it to here, and I'd call that a millimeter of ST depression. How about right there? What do you think that is? Yeah, I'd say that's ST elevation. So this is the type of ST elevation for some reason I see get missed. And I'll tell you what I always do. I always take an index card and I put it against the TP segments. Because if I put it right here and I can see ST segment above that, then there's ST elevation. So I put an index card and I line it up right here and right here. Sometimes it's tough because it can be a wavy baseline. You got to do your best. But if you see any ST segment over that index card, that is ST elevation. Then the question becomes, is it benign early repole? But we should not be calling benign early repole no ST elevation. Benign early repole is ST elevation, but benign. Okay. So what are some of the clues we use to decide if it's benign early repole? We look at the contour. Okay. So the contour with ST elevation is smiley face. So I can't remember if it's concave up or concave down, convex up or convex down, but I can remember smiley face. So if it's smiley face, do you think that means it's bad or good? It's good, right. So smiley face is good. What's that? That's frowny face. Good. Okay. So what are some other clues? So if you guys only remember one thing, I want you to remember the characteristics of benign early repole. Smiley face. Number 2, location. Nobody teaches us about location. Benign early repole, 95% of the time, is in the anterior leads. So if you see benign appearance, so smiley face, ST elevation in V1 through V4, most of the time, that will be benign early repole. Is that 100%? No, but it definitely pushes you towards benign early repole. It's in V1 through V4. Can it be in the inferior or lateral leads? Yes, but I would argue unless you feel like you are a really, really great EKG reader, every time you see it laterally or inferiorly, you should say to yourself, I'm going to really prove that that's not MI. Like, I'm going to either fax this or something like that, because anywhere other than the anterior leads is much less likely for ST elevation to be benign early repole. Okay, so it should be in the anterior leads. It shouldn't evolve. So if it's on a previous ECG, that's helpful. And if you repeat it, it shouldn't change. It's often associated with LVH. So I think it's useless for us to learn the criteria of LVH for diagnosing LVH, but I think it's useful because if there's big voltage, so it's useful to look at the voltage and understand LVH, because if it's there, that can help explain anterior ST elevation. That's another piece of information, okay? So this is a picture. You will never be 100% right. We are all going to make mistakes, but you're going to get closer to 100% if you use these features. And then finally, the fishhook contour in V4. Who's heard of fishhook in V4? Nobody? So 1, 2. So Fishhook in V4 is a very important concept. So this is, does anyone fish here? Okay, so does this look like a fishhook right here? Okay, there you have it. Okay, so this is the fishhook contour, and basically what it means is the initial part of that ST segment, instead of sort of coming off the QRS, is actually tented up. So there's like tenting of the initial part. If that's present in V3, V4, or sometimes V5, that's pathognomonic of benign early repole. There's only one thing that will give you this that's not benign early repole. Anyone? Hypothermia, exactly. So how do you tell the difference? Right, you check the temperature. Okay. So once you've checked the temperature, this is benign early repole. That is the best predictor that your anterior ST segment elevation is benign early repole. It's not 100%, but it's very good. Okay. So now let's look at this 45-year-old male from clinic that was sent in for the ST elevation, which I actually think was probably a good call on the clinic doc. And if you look right there, there is that pathognomonic fishhook. So this patient has, doesn't meet criteria for LVH, but has fairly nice size voltage. It's in the anterior leads. There, it's smiley face. There's a little fishhook there. So I am leaning seriously to benign early repole. So MI, I think we're all pretty good at MI, but let's just make sure we don't miss it. So frowny face contour, look for reciprocal changes. Reciprocal changes are important because they increase your diagnostic accuracy. So everyone comfortable with what reciprocal changes are? ST depression somewhere else on the EKG in a patient who's got ST elevation. And we're going to talk about that a little. Make sure it's in contiguous leads. If you have any questions, you can repeat it, but remember, repeat it pretty quickly, because if you have it repeated in 3 hours and it did evolve and then they sat there for 3 hours, that's not good for anyone's health, your own or the patient's. And then look for other findings of ischemia.
All right, well, I think that was a fantastic summary of some key points to distinguish benign early repolarization versus STEMI. So again, look for benign early repolarization, you're looking for ST segment elevation that has to at least be in the precordial leads, especially V2, 3, and 4. You're going to look for the fishhook pattern, especially V3 and V4, and those ST segment elevations have to be concave upwards, or as Jeff likes to refer to them, smiley face. If you don't have those characteristics, you need to be very suspicious that you're not looking at benign early repolarization. So there's a lot more to Jeff's EKG workshop, almost 3 hours worth of more information, great pearls. So check it out on CME Download, or please come to the Resuscitation Conference in Las Vegas, May 1st through May 5th. And there's going to be a lot of other really great workshops. Jeff's workshop is only one of them, and you'll enjoy it. So look forward to talking to you next month. Bye for now.